Okay, let's unpack this. You've sent us some really high-yield material on a condition that's crucial for anyone preparing for exams like the MSRA, but also just fascinating and important in clinical practice.
That's right. Today, we're doing a deep dive into Marjolin's ulcer. It's a rare but notoriously aggressive form of skin cancer, and really understanding its quirks is key, especially for recognizing it early when you might otherwise miss it.
Yeah.
We're going to walk you through everything you need to know from this material, covering what it is, why it happens, how it presents, and importantly, how we investigate and manage it.
Think of this as a focused revision session, distilling all the essential facts about Marjolin's ulcer into an easy-to-follow overview. Let's jump in.
Sounds good.
All right, diving straight in, what exactly are we talking about? What's the core definition of a Marjolin's ulcer?
Okay, so at its heart, it's a rare, aggressive form of squamous cell carcinoma. But here's the absolute key characteristic, the defining feature you need to remember. It arises specifically from chronic non-healing wounds or scars. We're talking particularly burn scars, but other long-standing problem areas too.
So it's not just a regular SCC popping up anywhere. It needs that pre-existing damage.
Exactly. It's cancer emerging from a long-term issue in the skin. While it's most commonly squamous cell carcinoma, it's important to note that sometimes it can actually be a basal cell carcinoma, or even less commonly, a malignant melanoma arising in that chronic wound context.
Right. And is there something about arising in a chronic wound that makes it different or worse?
Yes, and this is why it's high yield for exams and practice. Marjolin's ulcer, because it arises from this background of chronic inflammation and damage, tends to be more aggressive than primary skin cancers that develop on normal skin.
More aggressive how? Like faster growing?
Yeah, it can grow deeper and spread faster. This aggressiveness, coupled with the fact that it often just looks like a bad old wound, makes it a real diagnostic challenge. That's precisely why early recognition is absolutely vital. Its prognosis can be quite poor if treatment is delayed.
That makes sense. It's the wolf hiding in sheep's clothing because it mimics something benign until it's quite advanced. So let's dig into why this happens. What's the root cause, the etiology, and how does that lead to cancer, the pathophysiology?
Well, the primary cause is directly linked to that defining characteristic,
Yeah,
chronic inflammation or persistent trauma in the affected area.
right.
Imagine a scar, especially a burn scar, that never truly settles down over many years, or a long-standing ulcer that just won't close.
And that constant irritation somehow flips a switch. How does that chronic damage lead to malignancy?
Well, that chronic inflammation and continuous tissue damage creates an environment where cells are constantly trying to repair themselves. This long-term stress and repair process increases the rate of cell division, and crucially, it leads to the accumulation of genetic mutations over time.
Okay, so mutations build up.
Exactly. These mutations build up in the cells within the damaged tissue, and eventually they cause normal cells to transform into cancerous cells, leading to uncontrolled, aggressive growth.
So the chronic damage provides the fertile ground. And over years, random genetic errors build up until some cells go rogue. Given that, who is most at risk for developing a Marjolin's ulcer? What are the key risk factors?
The risk factors track perfectly with the cause. Anyone with chronic wounds or scars is at risk, particularly long-standing ulcers that haven't healed, and definitely burn injuries that result in significant scars.
Right, burns seem key.
They are. Other contributing factors can include chronic infections within a wound, and even exposure to environmental carcinogens in the damaged area. And an important risk factor highlighted is immunosuppression.
Ah, immunosuppression.
Yeah, individuals with weakened immune systems may be less able to control potentially malignant cell changes.
Immunosuppression makes sense. The body's surveillance system isn't quite as effective at spotting and destroying rogue cells. How common is this? What do we know about its patterns, the epidemiology?
Data on Marjolin's ulcer is actually limited, particularly in the UK, and it's generally considered a rare condition.
Okay, rare.
However, what we do know gives us a typical profile to look out for. It often appears in later adulthood, around age 59 on average. But here's a key point. That's typically a very long time after the initial injury, often 30 to 35 years later.
Wow, 30 to 35 years. That's a huge latency period.
It really is. It's also more common in men than women and frequently affects the lower limbs, which are, prone to chronic ulcers or significant burn sites.
That latency is crucial because a patient might not even remember the initial injury or connect it to the current problem.
Okay, the absolute most important part for spotting this in the clinic and for any exam. What does this actually look like when a patient presents? The clinical features, What are the red flags?
This is where you need to be a detective. You're looking for changes in a familiar landscape, an existing scar or chronic wound. The classic defining feature is an ulcer or wound that simply does not heal.
Okay, non-healing is number one.
Absolutely. If you have a wound that's been there for months or years and suddenly it starts acting up or refuses to close, that's a massive red flag. And what kind of acting up? What specific changes should we be looking for?
Pay close attention to these changes. Increasing pain, a chronic wound might ache, but a sudden increase in pain is suspicious. A foul odor developing, bleeding from the area, and the ulceration itself often has irregular, raised, or rolled borders.
So it's the change within an existing problem.
Absolutely. It's that sudden shift in character. Specific physical changes include induration. The area around or within the wound becomes hard to the touch.
Hardness, okay.
New or worsening ulceration, and nodularity, the development of lumps or firm areas within the scar or wound bed.
Are there any other subtle signs we might pick up?
Yes, you might also observe excessive granulation tissue that looks unhealthy, an increase in the amount or type of wound, exudate, or discharge, further bleeding, the worsening foul odor we mentioned, and any noticeable changes in the color, size, or shape of the wound over a relatively short period.
That paints a clear picture of stable problem area suddenly getting worse. Let's put this into a mini-case vignette like you might see in an exam.
Good idea.
Imagine you're in clinic and a 70-year-old gentleman comes in. He has a large, deep burn scar on his shin from an accident when he was a teenager, maybe 50 years ago.
Okay. Long history.
It's been stable for decades, but over the last few months, he says it's become much more painful. It feels hard underneath, and a small area within the scar that was just dry skin has now opened up into a foul-smelling ulcer that keeps bleeding and won't heal despite wound care. What should be high on your list of possibilities?
Given that history, a long-standing, stable scar, that very long latency period since the original injury, sudden increase in pain, induration, ulceration, foul odor, bleeding, non-healing, Marjolin's ulcer should be right at the top of your differential diagnoses.
Yeah.
That scenario perfectly fits the classic presentation.
Okay, so if we see a non-healing ulcer, especially in this context of a scar or chronic wound, what else could it possibly be? What are the main things we need to distinguish it from? The differential diagnoses.
That's a critical step. Not every non-healing ulcer is cancer, of course. We need to consider other causes of chronic non-healing ulcers, which are often more benign.
Like vascular ulcers.
Exactly. Things like venous ulcers, arterial ulcers, or diabetic ulcers, although these typically don't arise within old scars in this specific way. Simple benign scars can sometimes cause issues, but they wouldn't typically present with this constellation of rapidly worsening, painful, indurated ulceration.
What else?
Other possibilities include inflammatory conditions that mimic ulcers, like pyoderma gangrenosum, and importantly, a primary squamous cell, carcinoma, that arises on normal skin, which behaves differently to one arising in a scar.
Right, different biology, perhaps.
Potentially, yes. And of course, other less common malignancies could also present as skin lesions. The key is having a high index of suspicion for malignancy in any chronic wound or scar that changes character.
And how do we move from suspicion to confirmation? What are the essential investigations?
The absolute gold standard, the non-negotiable step to confirm the diagnosis, is a biopsy of the lesion.
Biopsy. Got it.
This tissue sample is sent for histological examination under the microscope to definitively identify whether cancer cells are present and what type they are. Beyond confirming the cancer, we need to assess if it's spread.
Okay, staging.
Exactly. So a thorough physical examination of the local lymph nodes is crucial, often followed by ultrasound imaging of those lymph nodes to check for any suspicious enlargement or appearance.
What about further imaging beyond ultrasound, if we're worried about spread?
Yes, imaging studies, specifically CT scans, are used if we suspect metastasis, meaning the cancer may have spread to distant parts of the body.
Where would we look?
The areas we typically check for spread include the brain, lungs, liver, distant lymph nodes, or kidneys. CT imaging helps us understand the full extent of the primary tumor locally and confirm if the cancer has spread to lymph nodes or other organs that might not be palpable.
So biopsy is the key first step, then check the local lymph nodes and image further if there's suspicion of spread. Once a Marjolin's ulcer is diagnosed, what's the typical plan? How is this condition managed?
Management is complex and needs a team approach. Decisions are always made within a multidisciplinary team, an MDT.
Right, the MDT.
Bringing together plastic surgeons, oncologists, radiologists, pathologists, and other specialists. The primary treatment, whenever possible, is surgical excision.
Cutting it out.
Exactly. This means cutting out the tumor with wide, healthy margins of surrounding tissue to ensure all cancer cells are removed. This is then followed by reconstruction of the resulting defect, often using skin grafts or local distant flaps depending on the size and location.
Are there specific surgical techniques used more often?
Yes, the most common approaches mentioned include wide local excision, which is that broad removal we just discussed. In some cases, particularly on the face or areas where tissue preservation is critical, Mohs micrographic surgery may be used.
Ah, Mohs. Okay, how does that work again?
Mohs involves removing thin layers of tissue, which are immediately examined under a microscope during the surgery. This process is repeated until no cancer cells are seen at the margins, allowing for precise removal while sparing healthy tissue.
Very clever. Are there ever situations where surgery isn't enough? Or maybe too much is needed?
Unfortunately, yes. In cases of very extensive local spread that simply cannot be surgically removed while preserving function or achieving clear margins, amputation of the affected limb might have to be considered
Right.
as a last resort to control the disease.
What about therapies like chemotherapy or radiotherapy? Are they used?
Yes, adjuvant therapies, meaning therapies given in addition to surgery like radiotherapy and chemotherapy, may be used, particularly if the tumor is inoperable, if the surgical margins aren't clear despite attempts, or if there's known metastasis.
And targeted therapy.
Targeted therapy is also mentioned as a potential option, depending on the specific molecular characteristics of the tumor. So yes, those are options in certain scenarios.
That's a comprehensive approach to help visualize the management, maybe a simple way to remember the core principles. An analogy, perhaps.
Okay, let's try this. Think of the cancer as a stubborn, deeply rooted weed growing in an old, fragile garden bed. That's the scar or chronic wound.
Okay, I'm with you.
To get rid of it, you have to pull it out completely. That's the surgical excision. But you need to take a wide scoop of soil around it, the wide margins, to make sure you get all the roots.
Right, clear margins.
Yeah. If it's a small weed, maybe just a patch of new soil is needed for reconstruction, like a skin graft. If it's a big, deep one, you might need a whole new section of garden bed built. Think of a flap.
Makes sense.
If the weed is spread everywhere or is too tangled to just pull, you might need powerful sprays or other treatments. That's your radiotherapy, chemotherapy, or targeted therapy to try and control it.
And the worst case?
And in extreme cases, if the weed has taken over the whole garden bed beyond saving, you might have to remove that section entirely. That's the amputation analogy.
That analogy really helps tie the different pieces together. Now let's talk about the outlook. What's the prognosis for someone diagnosed with a Marjolin's ulcer?
Unfortunately, because of its aggressive nature and tendency for delayed diagnosis, the prognosis for Marjolin's ulcer can be poor.
Okay. What affects it most?
Several factors significantly influence the outcome. The most critical ones include the stage of diagnosis. Is it localized or has it spread? The tumor size is important, as is the depth of invasion into the underlying tissues.
Deeper is worse.
Yes, and absolutely key is the presence of metastasis. If it has spread to lymph nodes or distant organs, the prognosis significantly worsens. The patient's overall health also plays a role in their ability to tolerate treatment and recover.
Given that aggressive nature and potential for spread, what are the potential problems that can arise either from the disease or its treatment? The complications.
The potential complications are serious and underscore the need for vigilance. The cancer can come back in the same area even after surgery. That's local recurrence.
Right.
It can spread, as we discussed, metastasis to regional lymph nodes or distant organs like the lungs or liver. Depending on where the tumor was located and how extensive the surgery or potential amputation was, patients can experience significant functional impairments.
Like loss of movement.
Exactly, affecting their movement or other bodily functions. And sometimes, especially after complex reconstructive surgery, patients can have issues with poor wound healing.
And is there anything specific done after treatment to monitor for these complications?
Yes, definitely. Because of the risk of recurrence and metastasis, the material stresses that long-term follow-up and surveillance are crucial after treatment. Patients need regular checks to monitor for any signs that the cancer is coming back or progressing.
That makes perfect sense, keeping a close eye on a condition this aggressive. Let's wrap up with a quick MSRA-style question, bringing together some of those prognosis factors.
Okay, let's do it.
Which of the following factors is least likely to negatively impact the prognosis of a Marjolin's ulcer? Is it A, lymph node metastasis, B, tumor size greater than 5 centimeters, C, superficial depth of invasion, or D, presence of functional impairment from the initial burn injury decades ago?
Okay. Well, based on what we just covered about prognosis, lymph node metastasis is definitely a major negative factor.
Right.
Larger tumor size, so B, also worse.
Hmm.
Deeper invasion is worse than superficial. Functional impairment from the original injury, option D, while impacting the patient's life, isn't one of the factors listed as directly impacting the cancer's prognosis itself.
So, which is least likely to negatively impact?
It has to be C, superficial depth of invasion. A superficial tumor actually has a better prognosis than a deep one, making it the factor least likely to negatively impact the outcome.
Exactly. Good spot. Wow, that was a really comprehensive deep dive into Marjolin's ulcer. We've covered everything from what it is and why it happens, right through to how it presents, how we diagnose and manage it, its prognosis, and potential complications.
Yeah, we covered a lot.
It really highlights how crucial it is to keep this rare but aggressive diagnosis in mind whenever you see a chronic non-healing wound, especially in the context of an old scar or burn.
Absolutely. The single most important takeaway here is recognizing that sudden change in an old scar or wound, the increasing pain, the hardening, the ulceration, the failure to heal after being stable for years,
That change is key.
it really is.
Yeah.
Having a high index of suspicion and pushing for an early biopsy makes all the difference because of its aggressive nature and potential for rapid spread. It's a classic example of needing to look beyond what seems like a simple, long-standing problem and considering the possibility of underlying malignancy, particularly in those at-risk patients.
Great points. Thanks for bringing this topic and material to our attention. They were perfect for this deep dive.
Our pleasure. Keep learning and keep those eyes peeled for those changing wounds.
For more free MSRA revision resources, visit freemsra.com, and for the full premium revision toolkit, head to passthemsra.com.